Welcome to Sisters in Sobriety. Today we're joined by Dr. Emma Kay, professor at the University of Alabama at Birmingham School of Nursing, and a nationally recognized researcher working at the intersection of HIV care, substance use, harm reduction, and recovery. Dr. Kay's work focuses on how healthcare systems can better serve people who are too often pushed to the margins, especially those living with HIV, while also navigating addiction, stigma, and structural barriers to care. Welcome, Dr. K.
Thanks so much for having me. I'm excited to be here.
Me too. Thanks for being here. So, for listeners meeting you for the first time, can you share a little bit about your path and what brought you into nursing, social work, and public health?
Yeah, so I definitely had a non-traditional path, but at the end of the day, I don't think I would change anything because I'm happy where I ended up. So, when I was in college, my undergrad was actually in biology. I was someone who really liked school. I kind of liked everything. Biology is a topic that can lead to a lot of different fields, medicine being one. It's like maybe pre-med, I wasn't really sure. Long story short, I did not go to med school. What I instead did was I went down the path of social work because I knew that I wanted to help people, but maybe not in the medical doctor type of way. So after getting my degree in biology, I ended up getting my master's and then PhD in social work. And I would say one of my most defining moments and what kind of led me down my research path was, so when you get your master's in social work, you have like these field placements and you can, ask for what you like, if you're like interested in children or older adults or whatever. Um, but what they really like to do, at least in my school, was to give you something completely outside of the bounds of what you asked for. So in fact, I did ask to work with children. At that time, that's what I thought I wanted to do. They're like, cool. So actually, we're going to place you in an HIV clinic. Um, and so I will say, and, I'm a little embarrassed to say it, but at that time in my life, I knew very little about HIV. I was a little bit uh, too young to have experienced like really the AIDS epidemic, that folks really saw in the 80s. And I just didn't know a lot about it. But I think that that really helped because I didn't have a lot of pre-existing notions. I just kind of went into it, with an open mind, and I really fell in love with the work. HIV is something that is, it is a chronic condition, but we have so much, we've made so many incredible bounds in medicine to where, you can be living with HIV or all you do is, take a pill once a day and it's not a big deal. So medically, it's not that challenging to have to live with. But in terms of stigma, it's still highly, highly stigmatized, unfortunately, and that's not really gotten better. We've had a little bit of a resurgence in our country of HIV stigma. And so, anyway, as someone who is a social worker and was interested in complex problems, I really fell in love with HIV. And then the intersection of HIV and substance use was kind of like a natural second step because so many people with living with HIV also have a substance use disorder. About half of people with HIV are estimated to have a substance use disorder. Um, and so then you have those intersecting stigmas, those intersecting needs in HIV care settings, in specialized HIV clinics, at least. The providers are highly skilled in treating HIV, and you don't see a lot of stigma. But when it comes to substance use, unfortunately, that stigma still remains, at least in the research I've conducted. And so you'll have people who aren't necessarily being stigmatized for their HIV in their medical care settings, but in terms of their substance use disorder, they're still being stigmatized. They're not necessarily receiving stigma-free care from their provider. In a lot of cases, that leads them to not feel comfortable disclosing it. And of course, that's not helpful for outcomes. So anyway, that is kind of my journey in a nutshell.
And so when you say 50% are at that intersection of HIV and substance use, that is greater than the statistic in the general population. So is there a chicken and egg situation there? What came first?
Yeah, and, it's interesting, like, certainly, it, like, either can come first, you can contract HIV through injection drug use, although we don't see super high rate of that. Most HIV is transmitted through sexual encounters. Um, in terms of other forms of substance use, it more so they usually coincide because of the same risk factors that would lead someone um, to acquire HIV are often the same that would lead them to engage in substance use. Also, substance use can kind of lower kind of your inhibition and can lead you to engage in more contactless sex, which can increase your likelihood of acquiring HIV. So, um, it really just depends what comes first, but yeah, it's interesting because a lot of people will assume that someone living with HIV acquired it through injection drug use, or at least I see that fallacy a lot, but the rates are so small compared to, other forms of acquiring HIV.
So at that early placement at the HIV clinic, what did you see there that really stayed with you?
Ah, gosh, I mean, it was such an incredible opportunity. I think one thing that really stayed with me was just the incredible openness of the clients that I worked with. So, I didn't have high expectations of vulnerability because I was a young student who clearly didn't know a whole lot about HIV. And so, maybe not the person you want to necessarily open up to, but these clients were so vulnerable, so trusting. So many of them had just these incredible stories of really resilience, I guess, is what inspired me. Like, yes, a lot of them had some challenging past with, trauma and sometimes like homelessness or just all sorts of intersecting factors. But ultimately, they were in care at the clinic. They were, doing everything they could to have healthy, fulfilling lives. And were still being vulnerable with me. And I just found that so um, powerful. And I just have so much love and affection for people who have gone through something like that and are still standing, and not only standing but thriving. And um, yeah, I think that's what really inspired me.
Did you see their addiction, and then did you see harm reduction, abstinence models there, and what did you think?
Yeah. So interestingly, I didn't really know much about harm reduction or see that come into play until I started collaborating with people outside of Alabama. So I've lived in Alabama for a while. I've gotten all my degrees in Alabama. Alabama is not a state that is very um, open to harm reduction models. We certainly don't have syringe service programs. We were kind of slow to get on board with things like naloxone or fentanyl test strips. Our models are almost exclusively abstinence-based here. So I didn't even know that there was another way to work with people with substance use disorder, again, until I started talking to and working with people outside of my own state. Um, it's just such a I call it a harm reduction desert here. It's not it's not available. It's highly stigmatized. Um, there's this mentality that I absolutely hate, which is that, harm reduction enables substance use is what I hear people say. And it couldn't be farther from the truth. But in any case, yeah, I abstinence-based models are the norm here.
You said something when you first started talking about it, is that, people are afraid to disclose substance use
Yeah,
sometimes to a healthcare provider. How often do you see that, and do you think that has something to do with the lack of options and that abstinence is really the only option provided in some of these settings?
completely. That's a huge factor. But also, I've really dug into over the past few years, um, like, I'm very interested in getting at, the question of how much do people know about harm reduction, like patients, clients, but also providers. And so I do a lot of research that's kind of trying to get at that because, if you don't know about it, then
Yeah.
it's not really an option on the table, right? And what I found is that unsurprisingly, a lot of people don't know about it. They don't know it's an option. Um, they haven't heard of naloxone. They haven't heard of any of the other options that exist that would be in the harm reduction umbrella. They've just heard, uh, well, yeah, I've got to stop using drugs and I've got to go to treatment. And I don't want to do that. Um, so it definitely needs to be, there definitely needs to be more education around it for people who use drugs, but also for providers. I've found it's not really taught in most curriculum, whether you're a medical provider or a social worker or a psychologist, what have you. And so that's part of the goal of my research too, is to just bring awareness um, to the need for more harm reduction education in our education, in our educational models.
And can you talk about what relational harm reduction is, and what does that mean in practice?
Yeah. So relational harm reduction is something that my colleague, Mary Hawk at the University of Pittsburgh, and I kind of are extremely passionate about. So, kind of the origin of this is we know a lot about um, what I call structural harm reduction resources. And I've already mentioned some of them today, things like naloxone syringe
Mhm.
service programs. Unfortunately, those aren't found everywhere, including my own home state. And so the landscape of structural harm reduction resources in the US are very piecemeal. But relational harm reduction is something that any provider can um, use in their practice, regardless of where they live, regardless of the policy context, because what it really comes down to is that patient provider relationship. So it's the relationship that you as the provider are building with your patient or client um, who has substance use disorder. So it kind of rests on these principles that are very similar to patient-centered care, but are specifically for people who use drugs. So things like pragmatism. So understanding that, um, people sometimes people who use drugs are going to continue to use drugs, and that's their choice. And so why not provide them with resources that are going to help keep them as safe as possible, right? Or humanism. So many times in medical situations, we don't humanize our patients, and we kind of see them as just their conditions or their disorders. Autonomy. So remembering that your patient has their own wishes and desires too. Incrementalism, so understanding that even steps that may seem small to you are um, may be big for your patient, and so kind of um, recognizing it and uh, congratulating them for any step towards health. Um, and then there are a couple of others too, but it just really gets at this concept of treating your patients with dignity and respect and care. And you can do that anywhere in the US. Maybe you don't
Mhm.
have a syringe service program near you, but you can at least try to mend um, maybe some of the hurt that your patient has experienced being stigmatized in other settings, and help create that space where they are comfortable to disclose. Because that's the other part of this whole approach, is not trying to guess, or assume that your patient is or is not using drugs. It's helpful to provide the same resources to everyone, regardless, right? So that it doesn't seem like you're trying to fish or like assume. Um, and that's something that we see in HIV testing too. Like the guidelines are, everybody should receive an HIV test at least once in their adult life, regardless, right? So it's kind of normalizing the experience in healthcare, rather than trying to, you know, figure out for yourself based on how a patient presents what their behaviors might be. So that's supposed to lessen stigma.
So when we talk about incrementalism, for example, what does that look like in practice?
Yeah, so I really really like incrementalism, because it can look like so many different things, but that can even be like, you have a patient who is injecting drugs, and then they switch to another form of substance use. Maybe now they're smoking, and technically that's lessening risk. And so that's actually a step towards health. But if you were to have the mentality that any substance use is wrong, and then you're cutting off that patient's ability to kind of make decisions that work for themselves, and that are technically decreasing potential risk and harm.
Yeah, that makes sense. And so what does healing or recovery, what can it look like when it's nonlinear?
Mm. And it so often is nonlinear. Um, and I try to I say that all the time in my research, is that it's not linear, and it's okay that it's not linear. I think we, as I don't know if it's our country or just humans in general, like things to be neat and linear, and they so often aren't. Um, but yeah, I mean, really, it comes down to centering um, the patient or client's desires and kind of goals as like first and foremost. So, you as a person have your own healthcare goals. My job as the provider is to give you the knowledge and the information and the resources that you need um, to do with what you will with. Like, so we can't force anyone to do things in medicine. We shouldn't. It's not really our goal. But again, it's like, here's where you get naloxone. Here's where you get test strips. If you decide you don't want to use drugs anymore, here's some really cool treatment options or programs that I would
Mhm.
suggest. Maybe you're using drugs because you have these other needs in life that aren't met, right? Um, Here's a referral for a therapist, or maybe you need stable housing. Here, go talk to these folks. Um, so much of like relational harm reduction, I think of as whole person care. So it's not just centering the person in their substance use. It's remembering that we're complex people with a lot of different needs. And it may take a whole network, a whole like referral system to really help you meet all the needs that you may have. But here are the resources, you know?
When you're looking at that intersection between HIV and addiction, do you think what ends up happening in the healthcare system is that they focus on that kind of more medical treatable piece?
Completely. Yeah, that always seems to happen.
Do you notice that there's subtle ways that, like, stigma shows up in these appointments, even when these providers think they're being neutral?
Yeah. Unfortunately, I do see a lot of stigmas still, and I don't think it's always intentional. It's just again, I see that as an opportunity for intervening with education. One thing that I hear providers say sometimes who are working with people with HIV is that they there there's this belief that so you have to take antiretroviral therapy or ART if you're living with HIV in order to keep the levels of the virus down and maintain health. And so there's kind of this belief I've seen among some providers that patients aren't going to be adherent to their HIV medication if they're using drugs. And I mean, sometimes that's true, but like sometimes any patient isn't fully
Mhm.
adherent to their medication because we're humans, right? But there's this natural like assumption that if you're someone using drugs that you're not going to be adherent. And so there's almost like then you're already kind of pigeonholing this person as well, they're not going to do what's best for them. Their their HIV is clearly not their priority. And that's not necessarily the case. But it's just that immediate assumption and kind of stigmatizing of a person using drugs that I see and I hear that is, of course, completely unhelpful to the patient. I mean, that doing nothing to further help. The other thing that I think I mentioned earlier that I hear all the time, if providers have heard about the term harm reduction, they often have an immediate knee jerk negative reaction to it because they're coming from a place of the only correct thing to do is to stop using drugs and stop using drugs immediately. And harm reduction is enabling drug use or prolonging it, or basically, I'm just not on board with anything in the harm reduction camp because they know what they need to do and they need to just stop using drugs. And so you're just bringing all these negative attitudes towards these patients who deserve the same level of respect and care as any other patient. And again, you're also making a lot of assumptions about their behavior, which is wrong.
So, that's so true that I think even regardless of what somebody's, like, illness is that kind of sends them to their primary care or to the doctor, a lot of times if you mention anything about substance use, it's like, "And here's a pamphlet for AA or NA." Have you
Yeah.
done any research about, like, is there a way? I mean, AA and NA typically they're abstinence-based. Have you
Mm.
seen, people try to fit harm reduction into those models, or is it impossible to do that?
Yeah, that's such a cool question. I don't think it's totally impossible. I'm not familiar with research in that area, but um at the end of the day, I'm a fan for whatever works for people and knowing that we're all unique and what works for one person may not work for someone else. So I think options are so important
Yeah.
for
I think it is a
patients.
little difficult to fit harm reduction into AA. But yes, I think I kind of it's
I
like,
mean, yeah, that's my first thought. But again, I'm nothing if not open to possibility.
and so when you look, at the advances you've seen, and so, yeah, if we look back 30, years, I'm trying to think back when I first started really hearing about HIV, and so now if it's a treatable disease.
Mhm.
Shouldn't we be looking at coexisting conditions like addiction more, or do you think we're still treating it, like we did 30 years ago, which is like, "Let's just fix this," and everything else is sort of secondary, or have the advances gotten to the point where we can start treating the whole person?
Yeah. Okay. I love that question. So, um, one thing to know about HIV is that um, it's definitely an aging population. So, yes, younger folks are still acquiring HIV, but by and large, and when you look at the average age of a person living with HIV, it's someone in their 50s or even 60s. That's what
I
we
didn't
see at
know
our
that.
Yeah, it's because
Oh.
we have people who acquired it back in the day and are still living and living well, right? Um, but these are folks who also have other conditions, things like diabetes, or diabetes is a common one, or heart disease, or just whatever. They're people who are getting older, and they typically have a lot of other health conditions. And so what we're really seeing in the field now is there's an incredible need um, for HIV care that is tailored to the needs of a person who is aging. So what we need is whole person care. However, when you look at the people who are treating HIV, who are, getting labs every 6 months from people with HIV and prescribing their ART, it's still a field where you see specialty clinics. Like, your average provider is probably like your typical like general care provider is probably not, could be, but probably not treating a person with HIV, because most folks, at least in Alabama, who are living with HIV are going to HIV specialty clinics. So I would love to see more providers be able to treat HIV. It's again, it's not terribly complicated. All you have to do is get labs every 6 months and prescribe a pill that you take every day, or an injection that you take every few months. And that's it. So we really do need to be looking at the other conditions that are the ones that typically do lead to fatality. It's not HIV, it's the other comorbid conditions that we're seeing with these folks who are aging.
Wow. So essentially suggesting that we treat it like we do any other chronic condition like
Like any other
diabetes, and that
chronic. Yeah,
the
yeah,
your primary care can manage it just by getting labs and prescribing your medication, and yeah, as you would with
yeah.
diabetes.
Right. It's been so othered, and it doesn't need to be.
Yes. And so what else is interesting is in the years you've been doing this, have you seen innovation though with HIV care, and have you seen addiction care not innovate that much?
How'd you know? Completely. I mean, the research and like HIV is something that where we've seen incredible bounds. I mean, it's incredible. I know it's something that, folks who initially acquired HIV back in the 1980s and still with us today probably never thought was possible. I mean, again, like now we have um, an injectable option, which really works so much better for some folks. Like, again, rather than taking a pill every day, with which doesn't work for some people, all you have to do is get an injection a couple times a year, and that's it.
Multiple times a year.
Yeah, I mean that's an incredible advance. Um, and we're getting better at. I think what's so cool about HIV research is that so much of it has been, how can we make living with this chronic condition a little bit easier on the person living with HIV. Like, I feel so many of these advances have just enhanced quality of life. And I find that so exciting. But yeah, when it comes to addiction, something else that is othered, by the way, because also um, a lot of providers are unwilling to treat substance use disorder when they could easily add that to their plate. It also is still put in this box of, well, you've got to go to a specialty clinic or a specialty physician. Um, and it's something where there's just been, in my opinion, even more resistant um, than HIV. Now, granted, I think naloxone is incredibly exciting, and I think that's definitely an advancement that needs to be celebrated. Um, but even that, there's still, so much resistance to getting naloxone everywhere it needs to be in the community, and educating people on how to use it and things like that. I mean, we've gotten better, but um, all that to say, I'd love to see more advancement and more excitement around improving the lives of people who use drugs, just like there is about improving the lives of people with HIV.
And do you see, I'm sure you do, but, can you tell us a bit about there a racism, poverty, gender, geographical gap in recovery care?
Yeah, definitely. So, it's something that we really saw around COVID is that for the first time, overdose rates were highest among Black and African American folks rather than white or other races. And so disproportionately, Black and African American people are dying from drug overdose still. And so something that I really wanted to um, to think about and to look into. So Alabama is one of those states where unfortunately, we're a southern state. There's definitely a history of racism and segregation and all those horrible things. Um, and harm reduction um, is sometimes seen by Black communities as like a white movement or something that is potentially meant to like further oppress Black people who are disproportionately being incarcerated for substance use. And so there's this like fear and concern around the word, and that's totally justified. And so I would love to see more harm reduction, like initiatives and programs that are led by Black and African American people, or even other communities who aren't necessarily white. Because when you look at who is leading this movement, you do see a lot of white faces. It's getting better, but considering that the overdose rates are disproportionately affecting people of color, we really needed to do something about that. And of course, a big part of that too is just less access and all of those things that unfortunately we see every day in the US. Um, so yeah.
So with that, yeah, what moves can communities make to close that sort of trust gap?
Yeah, I think just giving communities the tools that they need to lead their own communities. I think there's often this desire to want to come. So, Alabama is a very rural state. Where I live is more of an urban area, but so many of the counties are extremely rural. And you see a lot of researchers from my university kind of go into the more rural counties. And sometimes that's done right, and sometimes it's not. And when it's not, it's like kind of going in, collecting data, coming back out, not really empowering these more rural communities. I would love to see these rural communities um, create their own initiatives. But in order to do that, they do need more information. And I think they're open to that. It's just, um, unfortunately, a lot of times researchers don't do the best of trying to empower the communities that you definitely want to empower and not be someone who just dashes in to get something that furthers your career.
Yeah, that makes sense. And so if healthcare systems could change something, what single thing would make the biggest impact?
That is the question of the hour, right? um, the biggest impact, I mean, things just aren't affordable.
Hmm.
Um, you know, even so, like naloxone. So you can get it, over the counter, and that's great, but that costs pure like 45, $50 for a 2-pack. Um, that's really expensive for a lot of people, right? And so having access to resources that are more affordable would be great. And one way to do that is, hey, you're on your way out of your provider's office. Hey, why don't you take some naloxone? The cool thing about naloxone is it can be for anybody, right? It's good for people to have in the community. So I that's just like one example that comes to mind. But what prevents a lot of people from getting care is is cost. Same thing
Mhm.
with HIV. Um, so things were more affordable. I think more people would be able to get the care they need.
Yeah, I think that's so, so important. That's such an important point that sometimes gets missed when we have these conversations. And so, I don't Dr. K, thank you so much for being here today. I learned so much. I think everybody who's listening did too. And hopefully we will have you back and our next conversation will be about how great the healthcare system is doing with relational harm reduction.
I hope so. Thanks so much.
Thank you. And thank you all for listening to Sisters in Sobriety. And we will see you next week. This was Sisters in Sobriety.
Thank you for listening and being with us today.
If you want to learn more about sobriety and meet your community, find us at sistersinsobriety.substack.com.
Are you a sister in sobriety? Then reach out on social media. We'd love to hear from you.
If you're feeling generous, leave us 5 stars and a review and follow us wherever you listen.
You'll never miss an episode. Until next time.